Today I'll talk about the safety and efficacy of acupuncture for symptom management in breast cancer patients. I originally planned to talk about both CIPN and lymphedema patients, but for the time being, for today's presentation, I only included CIPN patients. I wanted to clarify that before I move on to the presentation. Just to briefly introduce the topic of my presentation, breast cancer risk in Korea is obviously very high. Number one, it's the most frequent type of cancer among women in Korea. And when it comes to the rate of increase, Korea is the only country at the moment with increasing rate of breast cancer in the world. On the other hand, when you think about the 5-year survival in Korea is relatively very high. Excluding thyroid cancer, breast cancer is one of the most highest type of cancer that has the very high survival rate. So when you summarize all this, you can see that the symptom management for breast cancer is very important, not only in terms of during when they're fighting cancer, but also when it comes to managing their symptoms even after they survive the period of cancer. When it comes to how to manage cancer symptoms, especially in breast cancer patients in the US, you can see that they usually include acupuncture as type of their management options, not only in clinics, but also in university hospitals. Acupuncture can be very safe and effective, but if you look at the side and pros and cons of acupuncture in breast cancer, you can see that while it enhances the quality of life and alleviates symptoms such as hot flash and nausea, this has already been explained in numerous literature, including Cochrane reviews. And also it's been proven to reduce pain. But on the other hand, there are issues such as safety and also unknown long-term outcomes and unwanted interactions. Now, I want to talk about the type of research that I am doing at the moment. I usually do, so earlier this afternoon, Professor Gu also mentioned the publication, but I also study a little bit of placebos in neuroscience, but I also do a little bit of data mining and data analysis, including real world data. So this is more of a translational medicine research than a basic science research. What we are doing at the moment is try to gather all the patients' data from the onset of cancer and try to follow them over time for at least 5 years to see if acupuncture does help in alleviating their symptoms or not. For this, what we are using at the moment is real-world data, including national health insurance reimbursement data. Now, this is exclusively very much available in Korea because we do, obviously, as you all know, we have national health insurance covering about more than 98% of all the national population. But also, we do include Medicaid patients who are not covered by national insurance, but also by government. So because we have a single insurer providing universal health coverage, we are able to obtain all the data of the whole Korean population from 2002 to 2020. When we look at the pros and cons of real-world data, what you will observe is usually disease codes. For example, ICD-11, ICD-10, or KCD-8 in Korea, and also lab test logs. So not the results of lab tests, but whether or not they received lab tests. For treatments covered by the NHIS, we can see the type of chemotherapies that are covered by the government. And acupuncture and moxibustion, when it comes to this, we cannot see, for example, whether they received, for example, distant acupuncture or proximal. We do not have any information about the type of acupoints, but we do have the information on the type of modes, for example, whether they received electroacupuncture or whether they received cupping or moxibustion. We do also have information on physiotherapies and also prescribed medications that are covered by national health insurance, and also costs and long-term follow-ups. What you do not observe in real-world data, including NHIS data, is lab test results, scales used to measure patients' conditions such as pain level, quality of life, and also possible heterogeneity among defined patients without proper steps, and also no information on acupoints in specific groups, as I mentioned earlier. So what I am about to introduce is cohort studies. And now cohort study is, if you look at the triangle over there, I'm not sure if it's working, but if you look at the red one over here, this is the cohort study. So it's basically slightly below randomized controlled trials. So we do see its level of evidence as not very low. It's about the middle level of evidence. So what we have for real world data is it's not designed and built for research. So we do have to process it again for research. So there is an inherent disadvantage in the application of RWD to research. But what we do know from RCTs versus what we need to know to provide optimal care is there still have a discrepancy. So there is an information from actual clinical practice in the real world data, for example, the current status. And we are able to observe effectiveness compared to usual care by emulation of pragmatic randomized clinical trials, a concept that was raised and enforced by Professor Ehrman from Harvard. So for NHIS data, what we do for analysis is specific definition of breast cancer patients, what we call operational definition. So we take patients that are diagnosed with breast cancer between 2011 to 2013 with no history of breast cancer surgery and no history of any type of cancer since 2002. And records of breast cancer surgery within 6 months of initial diagnosis. Now, this is done in order to provide at least some level of heterogeneity among the stage of cancer. And records of first chemotherapy and radiation therapy within 6 months of breast cancer surgeries, and first and second line chemotherapy and target therapy to define stages 1 and 2 of breast cancer. Now, for this, we had to get a lot of consults from oncologists and also physicians from the Western medicine field who actually treat breast cancer. And we were able to obtain the answer that many of the breast cancer patients in their first and second stage are treated by chemotherapies that are covered by national health insurance. So we were able to go on with this operational definition. Definition of Korean medicine or acupuncture treatments in clinical settings include number of sessions. And also for comparison, we adopted the concept of usual care, including chemotherapies, physiotherapies, and medications, except for over-the-counter drugs, which were not observed in NHIS data. Definition of treatment outcomes, usually we include events. For example, definition by diagnosis of lymphedema, diagnosis of CVDs, or death, and end of a series of events, or also event of the first prescription of certain drugs or prescribed opioids. Now I will move on to the topic of my research, which is chemotherapy-induced peripheral neuropathy, or CIPN. Now this type of neuropathy is specifically caused by chemotherapy, so it has to be excluding any type of other type of neuropathy, for example, diabetic neuropathy. And so this is chemotherapy and other cancer treatments can cause damage to the nerves away from the brain and spinal cord. So symptoms of CIPN include pins and needle sensation, pain, burning, numbness, sensitivity to hot and cold, difficulty with fine motor skills such as writing, buttoning, unbuttoning, and picking up small objects. Symptoms are usually symmetrical and start at the fingers and toes, progressing toward the body. For pharmacologic treatment of CIPN, this is usually the standard care, including duloxetine and sometimes including other type of per-oral medications such as gabapentin and tramadol opioids. But duloxetine is basically the only agent, by far the most evidence behind, currently recommended by ASCO for the treatment of CIPN. So other type of medications such as tramadol or gabapentin although they are prescribed at times by oncologists and physicians treating breast cancer, they're not exactly supported by ASCO with evidence for treating CIPN in breast cancer patients. For non-pharmacologic treatment of CIPN, this includes acupuncture, physical activity, and massage, including yoga and sometimes also meditation. Now, the research that I wanted to explore using real-world data in this case is acupuncture effective in CIPN treatment? I wanted to see if this reduced symptoms. But as I mentioned earlier, we are not able to see the level of pain using real-world data. So what we did is we observed whether or not this reduced prescription of pharmacologic agents. So we modified the research question to see, does acupuncture reduce prescription rate of pharmacological agents for CIPN management, such as duloxetine and tramadol? Now, this is the example of directed acyclic graph, or DAGs, often used in epidemiological studies to explain the research question and the study design. You can see that for our study, what we did is we included patients with breast cancer and those receiving anti-cancer treatment, such as chemotherapy, and patients who received CIPN. And we wanted to see if acupuncture actually reduces the rate of prescription for CIPN patients. Now, again, what we used is RWDs from national agencies, including National Health Insurance Service. So there were two choices. One was HERA and the other one was NHIS. What we chose in this case was NHIS database. And one of the reasons why we chose NHIS is because death records are only included in NHIS records and not in HERA records. So this was a major drawback for us when we are about to study cancer patients. For example, if we wanted to observe patients, for example, lumbar back pain, which we often observe in my affiliated organization, we can also use HERA. But for cancer patients, we had to choose NHIS database. So this is an epidemiological study, a nationwide cohort from 2002 to 2020, and we observed patients diagnosed with breast cancer from 2011 to 2013. I already explained the operational definition earlier, but we also had to move forward in defining the CIPN patients from here, which is initial diagnosis date, which is the first diagnosis of CIPN or G62.0. Patients were divided into groups by number of acupuncture treatments during the first year of CIPN. So 6 or more sessions were included in the acu group, and patients who did not receive any type of acupuncture were included in a control group. So this is the study design that we designed for this study. I have to apologize for these very small letters. I'm going to explain a little bit more. The very top is the exclusion criteria. So the light blue boxes include the exclusion and inclusion criteria, supporting patients, trying to exclude their history and trying to include their diagnosis. Now, dark blue include covariates. So they include pre-specified comorbidities, Charles Comorbidity Index, neoadjuvant radiotherapy or chemotherapy, and also adjuvant chemotherapy and radiotherapy prior to CIPN diagnosis. Now, the red box over there include exposure window or the treatment window, which is basically patients who received acupuncture. Now, at the very end on your right side is the follow-up window, which we had to include for 4 years. Now, because we included treatment window as 1 year, so basically we were trying to see a 5-year period after their CIPN diagnosis. So for the epidemiological study, it's very important to try to address any type of possible imbalance or try to address their confounders between acupuncture group and control group. So what we did in this case was using propensity score matching, or PSM. We could also do an IPTW method, but in this case we did a propensity score method in the attempt to do a very stringent and very conservative way of matching patients to try to match them in in their severity levels. For pharmacologic agents prescriptions, we included duloxetine, tramadol, gabapentin, amitriptyline. You're going to see them in our next slide. Then after a 1-year period was observed as the main outcome, and also during the 4-year follow-up period was used as an outcome variable for Cox regression models. So our model, excluding the sensitivity analysis, in our main analysis, we include 3 different results. First is Cox proportional hazard model. The second one is Kaplan-Meier survival curve. And the third is logistic regression of pharmacologic agents prescriptions by each year during follow-up. The number of patients having breast cancer between 2011 to 2013 are about 35,000. Now, among them, about 1,208 patients were diagnosed with CIPN after breast cancer diagnosis. All of them had no history of peripheral neuropathy, and also they had about 337 patients were in acupuncture group, which is about 28%, and 669 patients were in the control group. After propensity score matching, about 693 patients were in the cohort. We did a 1-to-2 matching, so for every 1 patient with CIPN and who used acupuncture, 2 controls of CIPN patients who did not receive acupuncture were matched with severe levels of disease severity. When after PSM, there were no significance between demographics, comorbidities including diabetes mellitus, and also depression. We had to include depression as one of our major covariates because duloxetine is also very frequently prescribed for depression. And also taxane's prescription were matched, and there were no significance after propensity score matching. And this is very important because CIPN is usually caused by taxanes in breast cancer patients. And this is the result of Kaplan-Meier curve. You can the red line is the acupuncture group, and the blue line is the control group over here. And you can see that the acupuncture group is always up above the line of the blue control group, indicating that they received less prescriptions. Or less patients in the acupuncture group were prescribed with tramadol than those in the control group. For duloxetine, the trend is very similar, but you can also see that less and less patients were prescribed with duloxetine than tramadol. Now you can see that also for duloxetine, acupuncture group had less rates of prescriptions in the 4 years follow-up period than those who were in the control group. Now, this trend was not shown in other type of medications, including gabapentin and pregabalin. You can see that for gabapentin, in the earlier periods over here, you can see that acupuncture group has a little bit of higher rate of prescription in the earlier days. For later days, the line usually is slowly matched. For pregabalin, you can see that acupuncture group had less rates of prescriptions, although this was not significant, statistically significant. For valproic acid, there were no significant difference at all. When it comes to amitriptyline, you can see that acupuncture group had higher rates of prescription in contrast to other results. Now, this is the result of the logistic regression. You can see for duloxetine, although there were no statistically significant results found throughout the 1 to 4 year treatment period, you can see that in the first 1 and 2 year post-treatment, there was a trend of less prescriptions rates of duloxetine compared to control group. And for the 2nd year post-treatment, the result was statistically significant. But this rate was not sustained after 3 and 4 years, meaning that after a 1 year period of acupuncture treatment, patients started to gradually receive about the same rate of duloxetine after 3 and 4 years. This is the result of tramadol. Now, the trend is a little bit similar for the first 2 years, meaning that it was slightly towards the trend of less prescription rates, although this was not statistically significant. And for opioids, I included this just to clarify the disease severity. For opioids, there were no significant difference at all. Now, I did not include opioids as our main results in Cox or Kaplan-Meier curve because the opioids included here excludes tramadol. And for Korea breast cancer patients, opioids other than tramadol is usually prescribed with the consideration of cancer pain rather than CIPN patients. So we cannot rule out whether this was prescribed for CIPN or cancer pain. For multivariate model, we adjusted for demographics, pre-specified comorbidity, including diabetes mellitus, osteoarthritis, rheumatoid arthritis, dementia, depression, and so forth. We included use of opioids and also other painkillers 1 year prior to CIPN diagnosis. And also, very important, we used use of taxanes were adjusted in the model. Now, experience of acupuncture treatments 1 year prior to CIPN diagnosis was also included to try to, in an attempt to adjust for their prior experience of acupuncture. Now you can see that for multivariate regression analysis model results, you can see that for tramadol and duloxetine, the result was statistically significant. In fact, tramadol's statistical p-value was 0.049, which is just right below the level of statistical significance. For valproic acid, amitriptyline, and gabapentin, and pregabalin, there were no statistic difference at all. Now, what is the difference between this and the prior result? This is basically a summary of all 4 periods rather than a 1 by 1 year period of prescription trends. Now for discussion, there were specifically and significantly reduced prescription of duloxetine, implying that there was a potentially effective management of CIPN symptoms and reduced medications using acupuncture. And this was robust throughout all analysis of Cox, Kaplan-Meier, and logistic and multivariate model. The same result were not observed in other medications such as valproic acid, amitriptyline, gabapentin, and pregabalin. So we therefore could rule out other types of possibilities of trying to prescribe duloxetine for example, depression. The effect lasted for 2+ years, and the prescription rate increased in 3 and 4 years. For opioids, for tramadol, the prescription rate reduced, which showed a rebound in 3+ years. Other types of opioids were not influenced, possibly related to cancer pain management. For gabapentin, pregabalin, amitriptyline, and valproic acid, the results were statistically insignificant, indicating that the results are not associated with management of other symptoms such as mood disorders and hot flashes. So for conclusion, we were able to conclude that CIPN management using non-pharmacological interventions was robustly effective using RWDs, and acupuncture on CIPN patients shows significantly reduced duloxetine and tramadol prescription. For long-term side effects of breast cancer patients such as CIPN, acupuncture can be an effective option. Now, this is my favorite quote. Thank you for listening.